Okay, ma'am. Okay, thank you. Kiran sir, can we start the recording, please? Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar session. Today's topic is DTG 10mg Overview and Case-Based Learning, and the speakers are Dr. Bhawani Singh sir from NACO and Dr. Sanjeeva GN sir from pCoE IGICH Bangalore. We welcome you both for today's session. Dr. Bhawani sir is unable to join us due to technical reasons. I now request Sanjeeva sir to kindly start the session.
Good afternoon. Thank you for that introduction. Okay, today we are discussing the national guidelines on DTG 10 milligram based ART regimen for children living with HIV/AIDS. And we all know that recently NACO has brought in DTG 10 milligram into the program, and there has been a lot of changes in the program, the way it is implemented on the ground. And as a result, there are a lot of questions now. I mean, there are a lot of problems and a lot of questions which are unanswered. And so we are trying to answer those questions through this session, where some of the questions which were raised in the previous sessions or during the other training programs were collated together, and this whole presentation has been prepared based on that. So the objective of this session is to just recap the first line ART regimen in ART naive children weighing less than 20 kgs, because the DTG 10 milligram is basically for children less than 20 kgs. So we are focusing on that. And DTG 10 milligram dosing in a special situation like HIV/TB co-infection, and the transition to DTG 10 milligram based ART regimen in children less than 20 kgs, and counseling caregivers for DTG 10 milligram based ART regimen, and monitoring these children based on that. So now, I mean, to get into the real issues today, let's know what are the goals of any antiretroviral therapy, whether it may be in children or in adult. The goals are same. What is the goal we are intended to achieve through the antiretroviral therapy? The first goal is to suppress the viral replication completely. That is the main goal. And through that we can achieve a lot of things. What are the things we can achieve by suppressing HIV replication? Is you can preserve, you can enhance, and you can reconstitute the immune system, and as a result you can reduce the opportunistic infection. We all know the biggest problem or a hallmark of any HIV infection is opportunistic infection. If you can control or you can prevent the opportunistic infection, you can definitely bring down the morbidity and mortality. So by doing this, we can reduce the morbidity and mortality. So as a result, you can improve the quality of life. And also in children, you can optimize the growth and development, and as well as this will result in a prolonged survival. This we all know. We have every one of us has experienced this over these years, how the ART has improved the quality of life, prolonged the survival. Initially, when we started off, we thought that these children are never going to live to see their adolescence. Now they are become adult, they have started their own family. So thanks to the ART, we have achieved most of these goals. Now with the newer drug, we want to have these goals achieved in more effective way, with a least side effects and prolonged regimens where your drug resistance may not be an issue in the long run. So now, what are the steps in preparing a child for initiating antiretroviral therapy? So the first and foremost is identifying a primary caregiver. We all know that children are dependent on others. They can't take care of themselves. So they need somebody else to take care of that. So our job is to identify who is that person who is taking the responsibility of taking care of of this child. So usually it will be parents. Suppose if the parents are not available, either they are dad or the adopted child or whatever it may be, so maybe the other family members. So we need to identify the primary caregiver as well as the backup secondary caregiver. If mother is the primary caregiver, probably the father will be the secondary caregiver or a backup caregiver. If mother is ill, mother is not available, or the primary caregiver is not available, they have gone somewhere. So you need somebody else to pitch into that job. So we also need to identify a backup caregiver. And then you have to do the initial assessment, which includes the baseline clinical and laboratory assessment, clinical WHO staging, laboratory assessment to look at the anemia, liver function, renal function, and other things also, along with that CD4 count. And you have to evaluate, diagnose, and manage if any of the opportunistic infections, if any are there, which includes tuberculosis. So look for opportunistic infection. If they are there, diagnose them and manage appropriately. And also do a baseline psychological assessment of caregiver and the child. So if any help is needed, you can provide that so that you can optimize the care of the child. And another important step before starting ART is initiating cotrimoxazole preventive therapy. So by doing this, number one, you are definitely giving a benefit of preventing opportunistic infection to the children. Can also address the issues of adherence while with the cotrimoxazole preventive therapy. So you can also identify the barriers for adherence. You can address those barriers, and that will also help in optimizing the adherence to the antiretroviral therapy. And then you have to do the ART preparedness counseling by preparing the child and the caregiver for the lifelong antiretroviral therapy. So also you need to stabilize any opportunistic infection so that you can prevent the any IRIS, that is immune reconstitution inflammatory syndromes. So now, so to recap, what are the steps before you initiate antiretroviral therapy? Okay, first and foremost is you have to confirm the HIV infection in infant or children. So if they are less than 18 months, you have to do virological test. If more than 18 months, you have to do serological test. After confirming HIV infection, you do the baseline assessment clinically as well as laboratory wise, and you do all the investigations required, symptom directed investigations and CD4 count. If there are any opportunistic infections or any acute conditions, especially in children like malnutrition, if it is there, you treat and stabilize the child, and then initiate cotrimoxazole preventive therapy or cotrimoxazole prophylaxis, and do the counseling to prepare the family for the lifelong antiretroviral therapy. And then initiate appropriate first-line antiretroviral therapy regardless of age or WHO staging or immune status. Okay, so now there is something called as a rapid initiation of ART. This concept is recently advocated by the WHO, and even our guidelines talks about this. But basically, WHO says rapid initiation is same day initiation, which may not be feasible in our setup. So what do we mean by rapid initiation of ART in our context is, it is advised in children with HIV initiate on antiretroviral therapy regardless of age, CD4 count, and WHO clinical staging. However, ART is not an emergency intervention. So ART preparedness and management of opportunistic infection is priority. It should be done first, and then you have to initiate ART. Any child who is seriously ill or hospitalized, child should be stabilized before ART initiation. So what do we mean by rapid initiation is, you can initiate ART before you discharge the child, whoever is admitted for serious illness or any other conditions. Now, DTG-based ART regimen, what is the advantage and why do we need this? We all know that DTG is more potent. It rapidly achieves and maintains viral suppression for a longer duration, and it also supports adherence through less pill burden and easy administration. And there are enough evidence to show the superiority of DTG as compared to ritonavir boosted lopinavir as well as efavirenz. And it will also harmonize with the adult regimen. So now we all got same regimen, adult and children. There are only few minor modification. As a result, it is very easy for us to maintain the supply chain. Lesser number of drugs to procure, so the supply chain management will be easier. So the advantage is simplified dosing schedule, easier administration, better taste, better tolerance and lesser side effects, faster viral load suppression, and high genetic barrier for resistance. So these are the advantages of DTG in children. Now ART regimen currently, abacavir is the preferred first line NRTI for ART initiation of CLHIV. Lamivudine is the second NRTI component for all patients, and CLHIV less than 20 kgs will be initiated on dolutegravir 10 mg based regimen. For children with a weight about 20 kgs, dolutegravir 50 mg film coated is recommended as preferred third drug. For all children aged more than 10 years and weight more than 30 kgs, tenofovir is the preferred first line NTRTI drug for ART initiation in children, just like adult. So less than 20 kgs, dolutegravir 10 mg along with abacavir and lamivudine. For children more than 20 kgs, dolutegravir 50 mg along with abacavir and lamivudine. For children more than 10 years and more than 30 kgs, tenofovir, lamivudine and dolutegravir will be the preferred regimen. So now we have ART regimen in children will be dolutegravir 10 mg. That's what I have just now narrated. So weight less than 20 kgs, you will have ALD, that is these 10 mg. A fixed drug combination of abacavir and lamivudine as per the weight band given twice daily, plus pediatric dolutegravir 10 mg tablets as per the weight band given once a day. Whereas children between 20 to 30 kgs, you will give ALD, that is abacavir lamivudine twice daily as per the weight band, plus DTG 50 mg once a day. So for weight above 30 kgs and age about 10 kgs, you will give TLD, that is tenofovir lamivudine dolutegravir once daily fixed drug combination. So we have to calculate the dose of abacavir lamivudine FDC along and DTG 10 mg as per the pediatric drug dosage chart, which is available in our national guidelines for HIV care and treatment 2021 annexure 2. So this is the dosage chart. You can use this. This starts with the weight band from 3 to 5.9 kgs up to more than 40 kgs. So depending on the weight of the child, you can use this weight band and you can adjust the dosage appropriately. So DTG 10 mg for children less than 20 kgs, the weight band between 3 to 5.9 kgs, you will have half a tablet for DTG. And for children with 6 to 9.9 kg, it will be 1.5 tablet. 10 to 14 kgs, it will be two tablets. 14 to 19.9 kgs, it will be 2.5 tablets. Now, when you are doing preparedness counseling, you have to answer these 3 questions for the patients. One is explain what you are giving and specify when you have to give and identify who is giving this. I think the first step is identify who. The primary caregiver, usually the mother or the father or a grandparent or a guardian. And it is essential to identify a backup secondary caregiver. And then explain what you are giving. So DTG 10 mg is a dispersible scored tablet. Scored means you can break it. Explain that a dose must be repeated if the child vomits within 30 minutes of taking the medicine. And when to be given, usually it can be given with or without food. Dose is once a day at a fixed time. Ensure the timing is linked with the routine of the child. Don't disrupt the child's routine activity just for the sake of giving the drug. So pre-ART activities like pill swallowing, giving first dose in the clinic or the hospital should be observed. So that will be that will help in training the parents. So how to use a dispersible tablet? Usually the amount of water you need to take will depend on the number of tablets. For anywhere between half a tablet to 4 tablets, you may need 5 to 10 ml of water. For anything above 4 tablets, you may have to take 20 ml of water. So take the 10 milligram DTG dispersible tablet. It should be dissolved in the drinking portable water in a clean cup. Take the required number of tablets as per the weight band in a cup. Add the measured amount of water. The amount of water depends on the number of tablets, as I've already mentioned. Suspension should be stirred so that no lumps are remaining. So once the oral suspension is prepared, it should be given immediately, maximum within 30 minutes of mixing. Add small amount of water in the cup in which the medicine was prepared and give it to the child. This additional, because there may be something which is sticking into the cup, so you may make sure that with the additional water, the full dosage is given to the child. DTG dispersible tablet can be swallowed as a whole beyond 5 years or whenever the child is ready. 1 tablet at a time can be swallowed to avoid choking. Scored DTG 10 milligram tablet can be split with a dry and clean hand. Unused half tablet can be used for a later for the next day or so. And remember one thing, if the child vomits within 30 minutes, you may have to repeat the dosage. You can use DTG 10 milligram dispersible tablet for children up to 19.9 kgs. For children above 20 kgs, you can use DTG 50 milligram film coated. So options for children more than 20 milligram not able to swallow film coated tablets are there are many. One is, the first option is you can use the same 50 milligram tablet. It may be split into halves followed by immediate ingestion of both halves of the tablet, or it can be crushed or added to a small amount of semi-solid food or a liquid. All of it should be consumed immediately. Remember one thing, is a film coated tablet. It is not a dispersible tablet. It's not easy to dilute into the in a water. It will not get easily dissolved into the water. You have to mix it thoroughly, then only it is possible to somehow make a solution of that. Or else you can give DTG 10 milligram DT tablet, but the thing is 30 milligram of DTG 10 milligram tablet is equal to 50 milligram of DTG tablet. So you remember one thing, if you are in a rare situation where you are forced to give DTG 10 milligram dispersible tablet for children more than 20 kgs, don't take it as equal, don't take 50 milligram as that, because the bioavailability of 50 milligram DTG film coated tablets is lesser than the 10 milligram dispersible tablet. So you need only 30 milligram if you are using dispersible tablet instead of 50 milligram of film coated tablet. So this point needs to be kept in mind if in some rare situation where you can't give 50 milligram film coated tablet for children more than 20 kgs. So instead of 50 milligram, you can give 30 milligram of dispersible tablet. But these are in a rare situation. I am stressing that point now. Now, so what is the relationship between the meals? I mean, when to give? So maybe given without meals. So 10 milligram dispersible tablet should be ideally dispersed in water, dissolved in water. It can be taken with a milk or food. It is dispersible tablet should be dispersed into a solution and given. If the child can able to swallow, then you can also give it directly to the child. Now, what are the counseling messages for this family while starting DTG-based regimen? So you should explain the need for lifelong antiretroviral therapy, and you should also talk about the importance of adherence and viral suppression, and why it is important to achieve and maintain complete viral suppression to improve the quality of life as well as to decrease the morbidity and mortality. You should also explain the benefit of DTG 10 milligram how effective it is, how safe it is, and how easy to administer. You may have to demonstrate how to administer this drug. You should also explain the common side effect, which include insomnia, fatigue, and headaches, rashes rarely, and these are very minor adverse effect. And most of the time, these are self-limiting. You don't need extra intervention for this. Only thing is you need to make the family to be aware of these side effects so that they don't get panic and which may result in poor adherence. So you need to make sure that they understand these side effects, which are self-limiting in nature and which can be managed on their own. So you should explain about weight gain due to DTG, and if there is a tendency towards an excess weight gain, then you may have to advise exercises and nutritional counseling. You should also explain how to give the drug. So 10 steps to be followed, which I have already discussed. Specify the dosing. Specific dosing is weight based, so dose will change as the child gains weight. You have to talk about this with the family. Otherwise, family may think that you are giving extra doses, so my child may have some problems. So you have to be very careful. You need to address these issues when doing counseling. Fix timing of giving the drug. Discuss with the parents the convenient time. DTG should be taken 2 hours before or 6 hours after taking some of these, like cation containing antacids or laxatives, sucralfate, oral iron supplementation, oral calcium supplementation, and buffered medications. So these are some of the key drug interactions with DTG. Carbamazepine, phenytoin, and phenobarbital, which are used as a anticonvulsants. So in these situations, try to substitute with alternative anticonvulsants. Nowadays, most of us, we don't use these anticonvulsants in children. If at all, if you are forced to use these, if you don't have any other alternative anticonvulsant agent, then you can give, you can increase the dosage of DTG. Instead of OD dose, you can give daily, twice daily dose. Some of these polyvalent cation product like antacids, multivitamin supplementation. So when you are giving this, you use DTG 2 hours before or 6 hours after these products are given. Rifampicin, which is used in anti-tubercular treatment, during that situation when you have to use concomitantly, instead of giving single dose per day, you can give twice daily dose. Amodiaquin, which is an anti-malarial agent, which we are not using quite regularly now. If you are using it during that time, you can use alternative antimalarial agent. Nowadays, we get better anti-malarial agents. Now let's run through some of the case scenarios where here there is this girl child, 2-year-old, has presented with persistent oral thrush. She has achieved normal developmental milestones. There is some failure to thrive. She is weighing just 6 kgs and height is around 72 centimeter. Her CD4 count is 18%. She has been recently diagnosed with HIV infection. Her hemoglobin is 7 gram per deciliter and tuberculosis has been ruled out. Now the question is, what is the clinical stage of the child, and is cotrimoxazole prophylaxis therapy is indicated in this child? I think I will answer on your behalf here. So she is having clinical stage 4 because she has got severe malnutrition, which is a stage 4 disease, and child should be evaluated by a pediatrician. Oral thrush is a if it is just a oral thrush, it is a WHO stage 3 disease. If it is associated with esophageal candidiasis, then it will be stage 4 disease. Since there is a normal developmental milestone, it is again fine. If there is a developmental delay, then there will be stage 4 disease. CPT is indicated, yes, for all children HIV infected, age less than 5 years, whatever may be their clinical stage or CD4 count, we need to give cotrimoxazole prophylaxis. So you have to initiate cotrimoxazole prophylaxis in this child. So this is the dosage. Now, what needs to be done before ERT initiation? Same thing, baseline investigation, including CD4 count and percentage, screen and manage opportunistic infection, including tuberculosis, preparedness counseling after identification of the primary caregiver as well as backup caregiver, CPT initiation and check for its adherence in the initial visits. Management of severe malnutrition is essential. or you may have to stabilize the child, which may need hospitalization. What should be the ART prescribed to the child? Consider age is 2 years, weight is 6 kgs. The preferred regimen is abacavir, lamivudine and DTG 10 milligram. The dosage, as per the dosage chart, it will be AL fixed combination of 60-30, 1.5 tablet twice daily, along with the DTG 10 milligram, 1.5 tablet once a day. So to summarize, confirm HIV infection, treat, stabilize acute condition and opportunistic infection, baseline CD4 testing and other laboratory investigation. What is the weight of the child? If the weight of the child is less than 20 kgs, give abacavir, lamivudine and DTG 10 milligram. If the weight is between 20 to 30 kgs, abacavir, lamivudine and DTG 50 milligram. If weight is more than, if the age is more than 10 years and weight is less than 30 kgs, then also you can give abacavir, lamivudine and DTG 50 milligram. If weight is more than 30 kgs in any child who is more than 10 years, if there are no renal disease, then you can give tenofovir, lamivudine and DTG. So the dosage of ARV in CLHAV is based on body weight. So pediatric dosing chart, please refer to Annexure 2 of National Guidelines for HIV Care and Treatment 2021. So to write prescription here, we have a child, there are 4 scenarios. 6-year-old child, weight 13 kgs, boy, hemoglobin 8 gram per deciliter, CD4 is 500 cells. So what is the regimen you are giving? Abacavir, lamivudine, fixed dose combination 60-30, 2 tablets twice daily, DTG 10 milligram, 2 tablets once daily. Along with, you have to treat the anemia, you can give iron and other supplementation. 7-year-old girl child, weight 19 kgs, hemoglobin 9 gram, CD4 300, and there are no opportunistic infection. So abacavir, lamivudine 60-30, fixed combination, 2.5 tablet twice daily, DTG 10 milligram, 2.5 tablet once a day. Also, you have to give, since the CD4 count is less than 350 here, you have to give cotrimoxazole prophylaxis, 1 tablet once a day. Along with the hemoglobin is slightly less, you have to give iron supplementation as well as vitamin B12. So a 3-year-old boy weighing 9 kgs, hemoglobin is not available, CD4 is 400, there are no opportunistic infection. The prescription will be abacavir, lamivudine 60-30 fixed combination, 1.5 tablet twice daily, DTG 10 milligram, 1.5 tablet once a day. Also, since the child is less than 5 years, you have to give cotrimoxazole preventive therapy, and the child weighing only 9 kgs, nutrition supplementation is also, nutritional counseling should also be done for this child. A 4.5-month-old infant diagnosed with HIV infection, weighing 4 kgs, no other opportunistic infection. So the prescription will be abacavir, lamivudine 60-30 milligram fixed combination tablet, 1 tablet twice a day, along with DTG 10 milligram, half a tablet once a day. Along with that, syrup cotrimoxazole 2.5 ml once a day. You also need to look at the nutrition of this child. 4.5 months, still 4 kgs. There are definitely nutritional concern. Look for immunization and growth and development of this child. Need to be carefully monitored. Another case scenario where we have a 2-year, 9-month-old HIV infected boy, Master Z, who presented with an altered sensorium since 2 days, along with cough with fever from last 1 month. So here we have a child with a prolonged fever and cough, and now all of a sudden he has developed altered sensorium. There is also history of contact with pulmonary TB. His father is having a pulmonary TB. So now the diagnosis here is tubercular meningitis. There are a few other things to be done before you confirming the diagnosis, but this is more likely to be a tubercular meningitis. He was started on anti-tubercular treatment 14 days back. His body weight was 9 kgs and CD4 is 14%. And hemoglobin is 9.8 gram per deciliter. Now, are you going to start cotrimoxazole prophylaxis for this child? And when should the ART be started in this child in the context of HIV-TB co-infection? Yes, CPT to be started in this child because the child age is less than 5 years. And also child is having stage 4 disease. So the dosage is 5 ml once a day. So here ART to be started up after completing 4 weeks of anti-tubercular treatment. So in all tubercular meningitis in children, you have to give corticosteroid as an adjuvant therapy for the along with the anti-tubercular treatment. So in any child with HIV-TB co-infection, the priority is to initiate anti-tubercular treatment, and ART to be initiated as soon as possible within 2 weeks of initiating TB treatment, regardless of CD4 count in children and adults living with HIV. When there is a signs and symptoms of meningitis, we may have to delay the initiation of ART for at least 4 weeks, because there may be a risk of iris, and iris TB meningitis is very dangerous, and there may be a lot of morbidity and mortality associated with that. So corticosteroid should be used as adjuvant therapy for the treatment of tubercular meningitis. So here, what should be the ART regimen with the dosage prescribed for him? So this child, since this child is also having TB and tubercular meningitis and on rifampicin based anti-tubercular treatment, the ART regimen will be abacavir lamivudine with DTG 10 milligram in a double in the twice daily dose. Usually we give once daily. Here we have to give the dose twice daily. So the dosage will be abacavir lamivudine 60-30 fixed drug combination, 1.5 tablet twice a day, along with DTG 10 milligram dispersible tablet, 1.5 tablet twice a day. And this double dose of DTG should be maintained up to 2 weeks of stopping anti-tubercular treatment. After 2 weeks of stopping rifampicin based anti-tubercular treatment, we can go back to DTG 10 milligram once daily dosage. So what are the modification required when you are when the child is on concurrent rifampicin based anti-tubercular treatment regimen? So if we are giving a DTG based regimen, you have to double the dose of DTG. Instead of giving once daily, we can give twice daily, and this should be continued till 2 weeks after giving the last dose of rifampicin. Suppose if you are giving a regimen where the child is on DTG and ritonavir boosted lopinavir, so not only you have to double the dose of DTG, you have to super boost the lopinavir ritonavir in the ratio of 1:1. And this modification again to re-emphasize that it should be continued till 2 weeks after the last dose of rifampicin. Now, the first line ART regimen with TB here is weight less than 20 kgs, fixed the combination of abacavir lamivudine twice daily as per the weight band, plus DTG 10 milligram twice daily as per the weight band. For children between 20 to 30 kgs, fixed the combination of abacavir lamivudine twice daily as per the weight band, as well as DTG 50 milligram tablet twice daily. For children above 30 kgs and above 10 years, fixed the combination of tenofovir lamivudine and dolutegravir once daily, plus an additional dose of DTG 50 milligram after 12 hours. So in this situation, you are going to give DTG 50 milligram in the morning and TLD in the night. So the dosage will need to be dosage will need to remain twice daily for 2 weeks after the last dose of rifampicin. In drug-resistant tubercular TB cases, no requirement of changing the dose of DTG, as no rifampicin in the drug-resistant TB therapy is used. So the dosage of DTG 10 milligram DT tablet in CLHAV with drug-sensitive tuberculosis where rifampicin based anti-tubercular treatment is used. So between 3 to 5.9 kgs, you have to give half tablet twice daily, 6 to 9.9 kgs, 1.5 tablet twice daily, 10 to 13.9 kgs, 2 tablet twice daily, 14 to 19.9 kgs, 2.5 tablet twice daily, and more than 20 kgs, 1 tablet of DTG 50 milligram film coated twice daily. Again, to re-emphasize, this modification is continued till 2 weeks after the last dose of rifampicin. And in case of drug-resistant TB where you are not using rifampicin, you don't need to modify the DTG dosage. Now, another case scenario where a 7-year-old HIV infected boy, presently asymptomatic, clinically stable, no OI, weight is good, 24 kgs, CD4 count is 364, hemoglobin is fine, other investigations are within normal limit. So, is cotrimoxazole is indicated here? No, it is not indicated because the child is first more than 5 years of age, clinically stage 1 disease, CD4 count more than 350. So you don't need cotrimoxazole prophylaxis in this child. What is the regimen you are prescribing for this child? So the regimen is ALD because weight is more than 20 kgs. So you can use DTG 50 milligram tablet. So the prescription will be abacavir, lamivudine 60-30 fixed combination, 3 tablets in the morning and 3 tablets in the night, and DTG 50 milligram once a day. Now, here we have a 13-year-old girl with HIV infection, ART naive, asymptomatic, clinical stage 1. She is weighing 38 kgs and hemoglobin is 10 gram per deciliter. CD4 count is good, 458. Renal functions are within normal limit. Other investigations are normal. Now, again, the same question, CPT is indicated. No, because age is more than 5 years. Clinical stage 1, CD4 count is more than 350. No indication for cotrimoxazole prophylaxis. So what is the prescription, ART prescription for this girl? So the ART regimen recommended for this girl is tenofovir, lamivudine, dolutegravir, the TLD, because she is more than 10 years, weight is more than 30 kgs, renal functions are fine. So you can use TLD. The dosage is 1 tablet of TLD once daily at any fixed time as per the patient convenience. Now the another question, all these time you are talking about ART naive children. Now what about the children who are already on ART? So you have to we have to do the transition to DTG 10 milligram based regimen. So the NACO office memorandum on DTG based ART regimen under NACP for CLHAV weighing less than 20 kgs was released recently in this year. So the guidance was released regarding the transition of children weighing less than 20 kgs to DTG 10 milligram based ART regimen. So the algorithm is, if the child is ART naive, straight away start with abacavir, lamivudine and DTG 10 milligram as per the body weight. If child is on antiretroviral therapy, that is ART experience CLHAV less than 20 kgs, look at the duration of ART. If ART is less than 6 months, then again you directly transit them to fix the combination of abacavir, lamivudine and dolutegravir 10 milligram as per the body weight without even worrying about the viral load test. If the child is on ART for more than 6 months, then you look for the viral load. You have to do a viral load test before transition. If viral load is less than 1000 copies, then there is a complete viral suppression. Then you can directly transit them to the DTG 10 milligram, as you can see here. Or if the viral load is more than 1000 copies, then you have to do the extended adherence counseling for at least 3 months and continue the same regimen and repeat viral load. If viral load is less than 1000 copies, then transit to the dolutegravir. If viral load is more than 1000 copies, switch as per the SSAP guidelines. Now here we have 4 scenarios. If the child is on abacavir, lamivudine and ritonavir boosted lopinavir as the regimen first before transition, and if viral load is suppressed, that is less than 1000 copies, so your regimen will be abacavir, lamivudine and DTG 10 milligram. If viral load is not suppressed, even after your EAC for 3 months, still viral load is unsuppressed, then look for the hemoglobin. Hemoglobin is more than 9 gram, then you can give zidovudine, lamivudine and DTG 10 milligram. If hemoglobin is less than 10 gram, then you continue the AL DTG 10 milligram, and then you probably have to refer this patient to the COE, pCoE for the SSAP. So then we have to find out the cause for anemia and treat anemia, and then probably you may re-challenge. Once the anemia is corrected, you can re-challenge with zidovudine. Okay, if the child is on zidovudine based regimen, zidovudine, lamivudine and ritonavir boosted lopinavir, viral load is completely suppressed, you can go for zidovudine, lamivudine, and DTG 10 milligram. If it is unsuppressed in spite of your EAC for 3 months, and if not previously exposed to abacavir, you can go to AL DTG. If previously exposed to abacavir, then the same regimen to be continued and refer the child to COE, pCoE for SASAP guidance. So here there are few quiz for this transition here. We have a scenario: abacavir, lamivudine, and ritonavir boosted lopinavir is the primary regimen, is the current regimen, and viral load is 200 copy. What is your transition? The transition is abacavir, lamivudine, and DTG. So if you have zidovudine, lamivudine, and ritonavir boosted lopinavir and viral load 800, so here also directly you can go to the ZL DTG 10 milligram as per the weight band. Same ERT, same line ERT. AL LPVR and viral load is 1200. You have to do extended adherence counseling, and after that you repeat viral load which is 600. So then AL DTG same ART regimen, and so ZL LPVR and viral load is 1800. After EAC it is TND. It will then your transition will be to ZL DTG same regimen. AL LPVR 1200 copy. After extended counseling, then your repeat viral load is 2600. Then this child will go for the second line regimen. If hemoglobin is more than 9 gram percentage, zidovudine, lamivudine, and DTG less than 9 gram percent, they maintain the same regimen AL DTG and switch to the other regimen as per the guidance from the pCoE or SASAP or COE. So ZL LPVR, your viral load is 1800 and repeat viral load is 10,000. Then if previously not exposed to abacavir, AL DTG will be your regimen, second line regimen. If previously exposed to abacavir, then AL DTG, ZL DTG to be continued, and under the guidance of your pCoE, CoE, and SASAP, you may have to switch to the alternative regimen. Now, there are few frequently asked questions which were which we identified during our previous interactions from the NACO team with all the stakeholders in the field during these NDLS sessions, during the capsular training. So some of these we are trying to address now. So one pediatric patient who was on AL LPVR and his viral load was more than 1000 copies per ml, and we did not have pediatric LPVR for 3 months, so we could not step up, and hence we referred to SASAP. What else could be done? I think if the child is AL LPVR and viral load is more than 1000, and if there is no LPVR available, then better to go for LPR DTG, and 3 months later you can see if your viral load is suppressed or coming down. If it is not coming down, you can go for the second line. So what should be done if the regimen contains abacavir? Abacavir is a film coated tablet, cannot be dissolved along with the DTG. I think that we have already addressed previously. Any film coated is not dispersible. So you can give the child to swallow the drug, or you can crush and you can powder it and you can add it to the milk or water and you can give it immediately. What to do with the excess stock which is not going to be utilized until 1 year? We want to ship patient earliest to pediatric DTG as pill load of pediatric LPVR is causing adherence issues. Now I think this is an operational issues. I think somebody else from the team, Dr. Purnima, must be there. She will address this issue. If you have an excess stock, there is another question here. There are sites where they don't have even for 3 months for extended adherence counseling and step-up counseling, enough stock there. We can relocate to those places where it can be effectively used. Or if there are any other plan.
Yeah. So may I add, sir? Sorry.
Yeah.
So in this case, if there are LPVR, because now the patient will be shifted to transition to DTG-based regimen, and going forward, we may not require as much LPVR. So approximately 2 to 5% of the patient would require LPVR, and rest all can be transitioned. So accordingly, the ART centers and the states can help the ART centers in understanding what percentage of patients between 2 to 5% they can keep that much, and rest of the patient based on what sir just guided in his presentation that how it has to be transitioned can be done. And if there is excess stock after calculation of 2 to 5% of the patients who would require LPVR, then you can inform our SCM team for relocation, the SCM team NACO. And one more point, sir, one more point I would like to add is regarding the Abicavir film coated tablets. So now all the pediatric formulations are dispersible under the program. So that is not an issue. Going forward also, we will have only dispersible tablets. So yeah. So over to you, sir. Thank you.
And when to begin transition of DTG? After completing the present stock of tab LPVR or before that? I think this question is already answered now. And don't worry about this stock. Definitely you need some amount of ritonavir boosted lopinavir stock for you in some situations. So by keeping that in mind, the rest of the things can be relocated, but the priority is to transit these children to the DTG as early as possible. Now, monitoring growth and nutrition, you have to do every visit. I think in every pediatric session, we are emphasizing on this growth and nutrition, very important. Just giving ART is not enough. You have to monitor growth and nutrition. If there is any flattering in the growth and nutrition, you have to address it as early as possible. Developmental milestone assessment, for a screening for tuberculosis, clinical monitoring for opportunistic infection and T-staging, treatment adherence, and most another important point is please calculate ARV dose as per the weight. This is very important. When you start these children on antiretroviral therapy, initial days, they will rapidly gain weight and they will cross the weight bands very fast. And if you don't keep an eye on that and you modify the dosage as per the weight band, these children will be underdosed. And this is one of the most common reason for early treatment failure in children. Definitely adherence is the first, it's the important cause. The first, if you look at the cause list, the first will be the adherence. The second will be underdosing, because we tend to ignore the optimization of ART dosages as per the weight band, especially during in the initial stage of ART initiation, when the child is bound to gain rapid weight. So please, at every visit, check body weight of the infant and child. Drug dosage need to be modified according to the change in body weight. Maybe you may have to keep a reminder, especially when they are in the borderline. So we know that in the previous this thing I've already mentioned these dosage. See, here, when the child is around 5 kgs, that is a borderline. So this child may cross the weight band in maybe a month or two. Similarly, a child who is around 9 kgs, you may have to keep in mind that this child is going to cross the weight band sooner. Similarly, any child who is around 13.5 kgs, you have to be careful. And 19.5 kg, you have to be careful. So you may mark whenever you see a child in these borderline, sitting on the borderline weight, you may mark in their case sheets or in their white card that this child needs a closer monitoring, or you may tend to forget when you are doing follow-up. So keep this in mind. So you can mark in a red or something, so that you don't miss that milestone of modifying the dosage. So the point is, please recalculate the ARV dose as per the weight and optimize the antiretroviral therapy dosages. So now there are a few other questions, like what is the age-wise blood sugar level, normal range to monitor 6 monthly blood sugar level in CLHAV. So in children without diabetes between the age 6 to 12 years should have normal glucose reading that look like this. Before breakfast, that is fasting blood sugar anywhere between 70 to 120 milligram per deciliter, and 1 to 2 hours after meals it will be less than 140. So increasing hyperglycemia in type 1 diabetic children, whether DTG 10 milligram should be stopped or changed to the other regimen. Current recommendation is you have to actively screen all patients for risk factors of hyperglycemia before DTG initiation, and regularly throughout treatment follow-up, as there is a possible association between DTG and hyperglycemia. In case of development of diabetes, it can be treated with standard DM protocol while maintaining DTG regimen. Suppose if the child is already diagnosed case of type 1 diabetes, then you don't need to um, uh, avoid giving DTG or changing to the other regimen, because this child is already on insulin. You may have to modify the dosage of insulin based on the control of glucose. So will CLHAV2 have weight gain on DTG? Based on the available literature, weight gain may be observed in adolescent receiving DTG, just like in adult. So long-term clinical significance of these changes are unclear. Further studies are needed in adolescent and children receiving DTG. Currently, we don't have literature in children, but there may be, if you can extrapolate from the adult experience, there is a risk of weight gain that can be addressed appropriately. So this case scenario where a 6-year-old child weighing 13 kgs started on abacavir lamivudine DTG 10 milligram on in July 2023. So this child was issued 120 tablets of AL and 60 tablets of DTG, that is 10 milligram DTG 10 milligram. He is taking 10 milligram DTG in the evening at 7 p.m. He has come for drug collection on 29th of July 2023. The pill box has AL 10 tablets and DTG 10 milligram 6 tablets. Write the prescription for this child and calculate the treatment adherence. The prescription will be AL DTG 10 milligram, AL 60/30 FDC, 2 tablets twice daily. That means 4 tablets a day. That's why we have given 120 tablets for 30 days refill, and 10 milligram DTG, 2 tablets once a day. So for that, we have given 60 tablets for 30 days. So to calculate the adherence, number of pills given minus number of pills balance into 100 divided by number of pills the patient should have taken. That is, pill should be taken days into dosage. This is the formula to calculate. So here, you can calculate that drug dosage per day, 2 tablets. So number of tablets with the patient on the day of dispensing, 30 days, that is 30 into 4, 120. The number of tablets should have been consumed in the day. It should have been 112. So the tablets actually consumed is equal to 110. So the 90% adherence to the AL and 96% adherence to the DTG. So overall, the adherence is 97%. This is how you calculate the adherence in during your follow-up. Now, to conclude, introduction of DTG 10 milligram pediatric tablet has made pediatric ART more potent and effective. It has harmonized and simplified the ART regimen across the different age groups. New regime has posed many implementation challenges. DTG is used across the different regimen, first line, second line, even third line. DTG is well tolerated. The few adverse effects reported are minor and self-limiting. Treatment preparedness and adherence counseling should be done before ART initiation and before transition to DTG regimen, as well as with every visit. So these are some of the charts which are available for your counseling, and this can be downloaded. Job aids, this can be downloaded. It's available in Hindi and English. I think if this can be translated to the local languages, it will also be helpful for other states. Any questions?
So there's one question in the chat box, and we'll open up for discussion also.
Okay. Can you just
Yeah.
tell me the...
Yeah, the question is, are we putting children weighing less than 10 kg on DTG 10 mg? If a child is on a zidovudine-based ART, then do we continue it as ZLD or ALD?
No. Can you just... where is this thing?
I'll share this. Give me 2 minutes.
Okay. If the child on ZL, we are putting the DTG 10 milligram for children less than 10 kgs. I think less than 20 kgs, we are using DTG 10 milligram. If the child is on zidovudine based ART, then do we continue it as... See, remember one thing here, what we mean by transition, it is transition to DTG based regimen. We are not transiting zidovudine based regimen here. If the child is on zidovudine based regimen and viral load is completely suppressed, we are just transiting them to the DTG. So your regimen will be zidovudine, lamivudine, and DTG. So we are not transiting them to the abacavir. You are switching to abacavir only if if the viral load is not suppressed. So that will become second line. Okay. If your viral load is completely suppressed, we are just transiting them to the, instead of LPVR, we are giving them DTG. Any other questions?
There are no questions in the chat box, sir.
Sir.
Participants
Yeah.
can unmute.
Hello.
Yeah.
Sir, Dr. Swami here, Mysore.
Ah.
So recently in capsular training, continuing with the same case scenario, the patient child is as ZLD, and if the child becomes like more than 10 kg and more than 30 kg, more than 10 years,
Yeah.
the same patient can be switched to TLD, or we have to continue ZLD only, transition?
No, currently we are not transiting them to any other regimen. Only we are transiting is D. So if the
But
child
the problem
is
is in the
maintained,
capsular training.
yeah.
In the capsular training, Dr. Jera was mentioning about the same regimen. If the child is on ZL or L, it has to be transitioned to the TLD if the child is more than 30 kg.
No, I don't think we have taken that decision now. I mean, what is the take on this with from the NACO?
Sir, yes, if the child has gained more than 30 kg of weight and is more than 10 years, then the transition to TLD has to be done, sir.
Okay.
That's what they are telling in the transition.
Okay. That's not come out in the slides now. Probably.
Okay.
Yes, and not in these. Yes, sir.
Yeah.
In the OM, it was mentioned in one of the OM, sir. I'll reshare if there is a confusion at the state level. I'll reshare it, sir.
I think that that OM should be reshared then.
Yeah, sure.
Thank you, sir.
But we are not transiting. Suppose if they are on ZL LPVR, and we are not transiting them to abacavir, lamivudine, and DTG. If viral load is suppressed.
Sir, as you rightly mentioned, it will depend on whether the patient is suppressed or not. If it is unsuppressed, then only we switch. Otherwise, we continue with ZL.
Yeah. So only when it comes to 10 years and 30 kgs, then only we transit them to completely to the TLD.
Hello.
Hello.
So there's one more question, that why we are putting the children less than 20 kgs on DTG, as you have said in one or two case scenarios.
Can you come back? What is your question? Less than 20 kgs?
We are putting less than 20 kg patients on DTG.
Yes.
So why we?
Hello.
Oh, ma'am, can you please unmute again?
Hello.
Yeah, please. Yeah.
Sir, why we are putting the patients with weight less than 20 kgs on DTG-based regimen?
I think that we have already discussed that the advantages of DTG regimen, which is very effective, potent, it will harmonize with the adult regimen, and the literature shows that it is superior to the even protease-based regimen versus protease-based regimen, as well as those are the reason why we are using DTG for even children less than 20 kgs.
So there is no weight band, like we don't have to put it for less than 10 kg or not. Any weight band below 20 kgs will go for DTG, right?
No, I mean, see, in children, it's always based on the weight band. So less than 20 kgs, the weight band, I mean, we are using DTG 10 milligram tablet. Correct? So the dosage, the formulation is DTG 10 milligram. The dosage is based on the weight band. That I have already mentioned. For child who is weighing 3 kgs to 5.9 kgs, the dosage will be half a tablet of DTG 10 milligram. For children who are weighing between 6 to 9.9 kgs, the dosage of DTG 10 milligram formulation will be 1.5 tablet.
So
for children,
the lowest weight that we can use DTG is 3 kgs.
3 kgs. Any child who is 3 kg and above, you can use DTG. So for children up to 20 kgs, see, I will tell you the basic concept behind using this 10 milligram tablet. The dosage required for children less than 10 kgs are varying depending on the weight. Okay. For any child above 20 kg, the dosage of DTG is fixed. You can give 50 milligram tablet. Correct? You understand? For any child, for any child weighing 20 kgs and above, the dosage of DTG is 50 milligram film coated tablet. That's it. Okay.
Yes, sir. That is true.
For children less than 20 kgs, the dosage will vary based on the weight. Unfortunately, we can't modify the film coated drug. That's why we are using DTG dispersible tablet for children less than 20 kgs. So there your dosage depends on the weight band.
Right, sir.
I think I'm clear.
Yes, yes.
Yeah.
So I had some confusion. It's clear now. Right. Thank you.
So there is a question, if the child's body weight decreases after initiation of DTG-based regimen, shall reduce the DTG strength? Yeah, definitely. I mean, if the body weight is reduced, then you have to reduce the dosage. If it has crossed the weight band, then you have to reduce the weight of the drugs also. Otherwise, you will end up with toxicity. The question is, there is another question here. If after initiation of your DTG-based regimen, we expect child to gain weight. In spite of that, if child is losing weight, then there must be some other reason for that. Unless you find out that and address that issue, then will end up with other problems. So this child may have malnutrition. This child may have undiagnosed or untreated malnutrition or opportunistic infection. So you have to. This is a very danger sign what we are seeing. In spite of your optimal antiretroviral therapy, if child is losing weight, then there must be something else going on. You have to identify and address that. I think how much water that we have already mentioned, depending on the number of tablets, anywhere between half tablet to 4 tablets, you can use 5 to 10 ml, and anything beyond 4 tablets, you may have to use 20 ml of water. DTG as ARV prophylaxis for infants. Currently, there are no recommendation regarding that, because the DTG currently approved worldwide is for children beyond 3 kgs.
Any more questions? Participants can please unmute their mic.
Question is, for CLHAV age less than 3 years, can DTG 10 milligram be used? Yes, we can use. Any child beyond 3 kgs you can use.
Dr. Purnima ma'am, any remarks or comments from your end?
Hello, sir.
Yeah, thanks, Shweta. I think there are questions. Let's take more questions.
मीटिंग चल रहा है भाई. कितनी बार बोला? 2 मिनट 10 मिनट नहीं बैठ सकते क्या?
Please unmute.
Hello, sir. There is this regarding ARV prophylaxis for DTG. So what is the limitation? Because there are sometimes situations where other possibilities are not, other options are not available, like zidovudine cannot be used. Patient mother failed on NNRTA based regime. Dopinavir cannot be given before 2 weeks of infant's life. So why DTG cannot be given as ARV prophylaxis?
Ma'am, currently the evidence, the recommendation or approval of DTG is for children above 3 kgs.
3 kg.
The data on children less than 3 kgs are not available. There are, there are side effect issues and other things. That's why the data is not available and it is not approved. Since it is not approved by the appropriate authorities, better not to use that situation. See,
more than 3 kg in that.
Hello.
Leena ma'am, please go ahead.
Yeah.
Yeah, then what other alternative we can't give zidovudine or
Ma'am, the thing is, the whole guidelines is for the majority of the situations. The whole guidelines will cover. If there are any few such special situations, I think we can take a case. Some decision based on the case-to-case things, ma'am.
Okay.
Yeah, there are some gaps. We can't say that our guidelines covers 100%. There'll be some gaps, and unfortunately, we don't have ready-made answers for those gaps. So let's take call during such scenarios on case-to-case basis.
Okay, thank you.
The question on DTG as ARV prophylaxis for HIV-exposed children has already been discussed.
Yeah.
Any more questions? Please feel free to unmute your mic. Okay, we'll hold the questions for some time. And Purnima ma'am, you can give your remarks and we'll go back to the questions later.
Thank you, Shweta, and I thank Sanjeeva sir for a very, very informative session. Because now all our pediatric patients, majority of the pediatric patients are being transitioned or initiated on DTG-10. So I hope all our participants have got their answers. And if there are any more questions, you can always reach out to us. However, one thing I would like to reiterate here, which I've been doing in the last NDLS as well, is ensuring, and this is very, very important for the ERT center as well as the respective SACs, that every ERT center should have a weighing machine. As Sanjeeva sir was mentioning again and again, he was reiterating on the dosage, which depends only on the weight. So it is important, unless we have a weighing scale, we cannot ensure that the appropriate dosage is given to the child. And then eventually viral load suppression will not be achieved if appropriate dosage is not given. So please ensure, if your weighing scales are not working, please ensure you have a working weighing scale. And plus, all the pediatric patients are being weighed every time they visit the ART center, so that like somebody was asking, that if the patient is more than 30 kgs and more than 10 years of age, what do we do? So we have to transition. We can only transition when we know the exact age as well as the weight of the patient. Similarly, for other less than 30 kgs also. So it is extremely important that we have a weighing scale. And then it has been observed that many of the ART centers have either do not check the weight. I'm not generalizing it to all ART centers, but there are few who do not check the weight every time, or their weighing scale is not working. So it is my request that please ensure that you have a working weighing scale and it is used for the pediatric patients specifically in every visit. Thank you, Shweta. I don't have any other additional comments. If there are more questions, we can take.
Yeah, there's one in the chat box. So this is regarding LFU CLHIV. The patient was ZLE exposed in the past and now has become LFU, now refound. The current age is 12 years and the weight is 19 kg. ZLE exposure hardly 4 months, no viral load is done.
I think, there are a couple of things here. So this child is, if you look at, this child who had received ZLE previously, LFU, now, okay, weight is 12 years, but weight is still 19 kgs, less than 30 kg. So we can't give, we can't go to the tenofovir. So since it's already exposed to zidovudine, I would prefer to give zidovudine, lamivudine, and since the efavirenz is not is already phased out, maybe DTG can be given here. And the one thing is, zidovudine mutations are not very well archived, so we can still still expect that this virus will respond to zidovudine, and the duration is also short, so we don't expect many. See, for example, if the scenario we would have seen when there is no transition happening, so everything was available, ZLE is still available, what we would have done, we would have given ZLE and we would have monitored the adherence, and we would have looked at the viral load after 6 months. If well suppressed, then we would have considered it as first line. We would have considered the first line, continuing the first line. Similarly here, but since the efavirenz is phased out, DTG is there. So I would like to give zidovudine, lamivudine, and DTG 10 milligram because still weight is 19 kgs, 10 milligram, and step up the adherence. And after 6 months or after 3 months, I would do a viral load, or after 6 months, I would do a viral load. And then if viral load is completely suppressed, I will continue the therapy. If viral load is not suppressed, then probably I would go for the second line regimen, ALD. These are very tricky situations. We don't see it quite often. These are again case-to-case basis. You may have to call your SAPs, COE or pCoE, and you have to take a call based on that.
Thank you so much, sir. Thank you for this informative session. Thank you to Dr. Bhawani, sir, in absentia. Thank you to Dr. Purnima, ma'am, for being there with us. The session PPT and the recorded link will be shared with all the ART centers. In case you don't get it, please reach out to us and we'll share it separately also. I'm just sharing the DTG job aids for you. You can download it through the QR code. When you receive the PPT, you'll also receive the QR codes with it. Kiran sir, can you please confirm if the screen is visible?
Yes,
It's visible.
Thank you. Thank you so much, sir. Thank you to all the participants for patient listening. We are keeping the screen for 5 minutes. Please feel free to download the QR codes. The DTG job aid is available in English as well as in Hindi. Thank you, everyone. We'll conclude the session now.
Thank you.
Thank you, sir.
Thank you, sir. Thank you, Shweta.
Ma'am.